Hello everyone. Welcome to another Rafael Medina subspecialty virtual morning report. The topic today is clinical reasoning, and I'm extremely excited for this case and session. We have two excellent physicians from coming to us from Yale. And if you don't mind, Dr. Chang and Dr. Arcieri, if you can introduce yourselves, that would be fantastic.
Dr. Arcieri, would you like to go first?
Sure. So my name is Mike. I'm a third year at Yale Traditional Internal Medicine program. Prior to this, got my MD at the University of Pittsburgh. There, graduated with an area concentration in addiction medicine and in residency now in the clinician educator tract. Plan after is to become a hospitalist, academic hospitalist, and hopefully to stick around the area as well. Oh, and then one thing I'm grateful for. I do Blue Apron, and I've got some good recipes coming this week. Sort of really like making ramen, so there's kind of a lot of ramen this week. Grateful for that.
Thank you. And to the listeners, we are not sponsored yet. And Dr. Chang?
So my name is John Chang. I've been working at Yale since I trained there many years ago. I've been primarily working as a hospitalist. That's my primary duty. And then I do attend one half-a-day clinic at the Yale Hypertension Clinic. And so that's most of my clinical work. Outside work, I have I'm married, had two beautiful girls, 14 and 12, and a dog who's very affectionate. So I enjoy spending time with them at home when I'm not working. So grateful for this opportunity to come and discuss a case with you. I'm a little nervous, but I will do my best to try to work through the case with you all. So
we're very excited. And John, we wanted to ask you, why should trainees go into hospital medicine, or why do you think that is the best field out there?
Yeah, so I think hospital medicine, if you like medicine, I think a lot of us were drawn to internal medicine because of learning physiology, pathophysiology, and understanding how disease process work out in patients. I think it's a really good discipline to learn physiology. And because you see a lot of these things, very sick patients with a number of acute, issues happening right in front of your eyes. And then the other, I think, satisfying thing is you deal with the real issues. I mean, you're certainly the primary care doctors have a role, specialists have a role, but there's something about patient coming in with a single or a few problems, and you address them, and then when they leave, most of them end up going home with hopefully feeling better. And so, and then and if you like teaching, I think it's also a wonderful place to be, because if you're working in an academic center, you'll have a lot of residents and medical students rotating through, and I think it's a place for growth. You grow as a clinician, you can grow as a teacher, and lastly, I think if you're interested, there's a lot of opportunities for administration. You can do quality and also research. So it's not just seeing patients. There's a lot of other things you can get involved in being a hospitalist. So, yeah.
Yeah, thank you for that. Hope that is inspiring to all the trainees listening. Mike, if you want, we can go straight to you and start with the first aliquot.
Sounds wonderful. Okay, so Dr. Chang, this is a patient whose chief concern is 3 weeks of sleepiness and falls. So the following history is provided by the patient's girlfriend, as the patient is currently unable to provide a coherent history. So this is a case of a man in his 50s who was in his usual state of health until about 3 weeks ago, when he slowly but progressively became more sleepy. This was sort of complicated then by frequent falls and increased need for help with ADLs, when he was prior to this independent and sort of all ADLs. The girlfriend also witnessed what she calls tremors when he was holding onto a shopping cart 2 weeks ago. Since then, he's not able to go out in public and sort of get around in that capacity since then. Regarding other review of symptoms, the patient sort of intermittently becomes more lucid and states that he has chronic abdominal pain, but it's, quote, the same as always. He does note, quote, everything is more swollen now. And the girlfriend does confirm that the patient has diffuse swelling of the extremities and around the eyes that's gotten worse over the last 3 to 4 weeks. He also does comment on weight loss. Of note, he previously did not have steady access to food and endorses he believes the chronic weight loss is from that. Worth noting that recently he did move in with a friend where food is now consistently available. I'll stop there.
Yeah, John, I know we got a lot of information in the first aliquot, so just wanted to see how you would think about this presentation, or how are you framing this patient's concern of sleepiness?
Yeah, it's a interesting case. So I would probably frame sleepiness and fall. It's the conditions that cause sleepiness and fall probably fall into similar buckets. So when I think about sleepiness and fall, I would probably group them into probably 3 or 4 big categories come to mind. So the first thing is any patient who comes in with, I would even call this an altered mental status. The first thing I would think about is infections. Now, it's a little odd that generally speaking, patients with infection, they'll present with a few-day history of sleepiness and altered mental status, and then they usually have localizing symptoms or fever. But the fact that this has been going on for a little bit longer than that, and it sounds like he's had periods of lucidity, makes the infection less likely. The other thing I would think about is the big thing is medications. So especially how old is he? He's in his 50s. So certainly in patients who are older, you would want to do a good medication reviews to see whether or not the meds, the doses make sure that they're not new medicines, and then any of those medicines that can potentially cause altered mental status, be it anticholinergic, gabapentin, baclofen, any opioids, or Ativan or benzo. So I would try to do a good medication review. Interestingly, that you mentioned that he had a new swelling. You wonder whether a patient has had some renal issue that's going on, perhaps nephrotic syndrome, that's causing him to have a concurrent renal failure. And anytime you have a patient with a renal failure, you have to look for medications which are normally cleared by the kidneys. And when it's not cleared by the kidneys, you can develop a altered mental status, classically the gabapentin. And so I would certainly think about medications as a possibility. Interestingly, he said tremor. So that also, certainly a patient with a gabapentin toxicity can present with a myoclonus. And so I don't know exactly what's meant by tremor here, exactly what, so that would be something I would want to know exactly what is it that she's seeing. Let's see, and then there are a few other medications, I think that will become obvious when we look at it, like Depakote would be another one, but the medication would be pretty high on the differential. And then the third would be some kind of electrolyte abnormalities. And when I think about electrolyte abnormalities, I try to think more systematically. So many of you are familiar with the skeleton that, I don't know what its official name is, but sodium, potassium, bicarb, chloride, BUN, creatinine, and glucose, and then divalence. So I go through them quickly. So the sodium concentration, hyper and hyponatremia can both cause altered mental status. Sodium level generally has to be over, for hypernatremia, 155 or 60, hyponatremia, 120 or lower. And then potassium does not cause altered mental status. And then chloride and bicarb, chloride by itself is not very useful, but the bicarb certainly, for whatever reason, is a retaining CO2. And so that would be something I would want to know. And then BUN and creatinine, unlike, so there's a bit of a misconception about how the uremia causing altered mental status. Acute kidney injury does not cause altered mental status. It's really in the setting, when you see altered mental status in the setting of AKI, it's the medications. It's gabapentin, we see this all the time. some other medicine, pregabalin potentially, but it's, the cases that I've seen most commonly, it's really medication induced. And then the calcium level would be other thing you would consider. Hypercalcemia, generally the level would have to be, at least 13 or more like 15 or higher before it will cause altered mental status. MAG and the FOS does not cause altered mental status. Ammonia level would be another thing I would be interested in. I would want to know whether he drinks alcohol, and if he does drink a lot, maybe this is, he's presenting with a new cirrhosis, and clearly certainly the weight gain would be consistent with ascites or a lower extremity edema, as in the setting of portal hypertension. And so those are electrolyte issues that I think about. And then the other last sort of category, or two other categories, some kind of a structural problem. And so you would have to have an increase in intracranial pressure. And so, could this be a manifestation of new, some kind of a brain mets that's presenting like this? And then lastly, if you run through all this and then patient doesn't have anything else, then it may be a psychiatric issue. So I'll stop there.
Thank you so much for such the broad differential. Back to you, Mike. Can't wait to hear more.
Absolutely. So we'll round off the review of systems, again, through the girlfriend's memory. So to the best of the girlfriend's memory, patient does not have dyspnea, no orthopnea, no PND, no jaundice, no melena, no hematemesis, no paresthesias, or medication misuse that she knows of. In terms of his past medical history, there are several diseases worth noting. So first, he has a complex GI history, including recurrent ileitis, colitis, which 30 years ago required a colostomy for a short period of time. He had a gastric perforation, which required an XLAP a year prior to this admission. And actually, during that admission, they found him to have over 30 gastric as well as duodenal ulcers. He's never had formal diagnosis of these issues. He basically has declined endoscopy, other than when it was emergently needed. But IBD is highly suspected by gastroenterologists who have seen him, though not confirmed. Second, he had an unprovoked PE 6 months prior. In addition to that, around the same time, he had an admission for inferior STEMI that required stenting to the RCA, and also had stents placed in the LAD. Fourth, he has this very sort of vague history of prolonged altered mental status that actually was severe enough to require a trach and a peg placement for a period of time. That was a few years ago. Not really a clear cause. It was sort of thought to be secondary to opioid misuse, but it wasn't sort of terribly convincing given the length, of course, of time that he was altered. And then he also has hypothyroidism with intermittent adherence to levothyroxine replacement. And then lastly, he does have opioid and cocaine use disorder, a mood disorder, and chronic abdominal pain. His medications are also, there's many. He has pantoprazole BID, apixaban, aspirin, Brilinta or ticagrelor, metoprolol tartrate, levothyroxine, buprenorphine, methylphenidate, aripiprazole, trazodone, venlafaxine, gabapentin, and scheduled acetaminophen, which is 1,000 TID. In terms of his social history, actually, I should ask, should we stop there, or would you prefer I move on to social history?
I think it's a good idea to stop right just for now. John, we got a lot of information. Which of this past medical history stands out to you, and how are you framing it in relation to the patient's presentation?
Okay, let me just look at the past medical history again. Let's see. So I think certainly given his history of hypothyroidism, I would want to know whether he's been taking it, and also whether or not the thyroid was being absorbed properly given his GI history. So that's, I think, would be something would be relevant. And then I would like to know what the dose of gabapentin is, and and you mentioned, is he, but he's not on any opioids, or is he on buprenorphine right now?
He is currently on buprenorphine. That's correct.
Yeah, okay. That would be, I guess, unlikely to cause significant altered mental status. But I think those are two things that just immediately jump out at me: the gabapentin dose, and then whether the history of how he was taking his thyroid medicine. And then let's see, any other medicine, the trazodone, aripiprazole. And then only other thing I would want to know is, has he been eating and drinking normally? Again, this would be very unlikely in a patient in the 50s, but I've seen at least one patient who comes in not with altered mental status every time he's little volume down. And you give him 1 liter of normal saline, he wakes up. And his son said, yeah, every time he comes in, he gets volume depleted. I mean, comes in and gets 1 liter of normal saline, he feels better. And it's not really an electrolyte problem. I mean, he's not really hypotensive. He's not volume depleted enough to cause hypotension or renal failure, even for that matter. But sometimes the subtle volume depletion can cause altered mental status. But it would be unlikely in a patient who's 50. And then I would want to know whether or not, because in the setting of, since we're talking about gabapentin, I would want to know whether he's been eating and drinking, make sure that he's not in prerenal AKI, which can certainly cause a gabapentin toxicity. Just the gabapentin, that the range of dose you use is as high as 3,600 milligram a day. In patient with normal renal function, that's 1,200 milligrams 3 times a day. In patients on dialysis, it's about 100 milligrams on the dialysis day. And so you get a huge range of dose range for gabapentin. And so even if patient who's taking what seems like a moderate amount of dose, let's say 600 milligrams 3 times a day, when they come in with a renal failure, they will develop altered mental status. I just had a patient who probably overdosed on baclofen and gabapentin last week. So in that setting, I think that would be, given his GI history, again, I want to know how well he's eating, and also whether he's having diarrhea. And then likewise, in the vein, was he taking all these medications, including gabapentin?
To answer a few of those questions, they're not all of them. So recently, it sounds like a couple months ago, not so good in terms of eating. More recently, has gotten access to food by staying with a friend. Previously unhoused, which we'll talk about in just a second. And the gabapentin dose is fairly high. It's 800 TID.
Yeah, and does the history of the exploratory laparotomy make you think of vitamin deficiencies as like an etiology, or is the timing of 3 weeks make it less likely?
It's a good question. Honestly, I don't know the answer to that, but generally speaking, I think I guess the question is, what kind of vitamin deficiency can cause altered mental status like this? I've never seen B12 presenting like this. I've seen few, we see some mild cases of B12 deficiency. Thiamine deficiency, perhaps, but again, I don't have any experience in taking care of a patient. It's usually we think in terms of we think of that in the context of alcohol use. So certainly that would be a possibility. I don't know if there's any history of ataxia that the girlfriend noted, and then I guess during exam we can see whether he has nystagmus to see but that's a great thought. Yeah.
Mike, back to you.
Absolutely. So next is the social history. Previously unhoused, though now he lives with a friend, like we mentioned. He's been out of work for about 5 years, but prior was a mechanic and a landscaper. He's no longer working, secondary to his chronic abdominal pain. He has a 20-pack year smoking history and does currently smoke cigarettes. Has a remote alcohol use disorder, has not had a drink of alcohol in the last 10 years, also has an opioid use disorder, which is also in remission on buprenorphine, has not used opioids in the last 6 months. He does actively use cocaine. His family history is non-contributory. And I will stop there.
Okay.
John, any other thoughts before we go to the vitals and physical exam?
Sure. So if he's using, how much cocaine is he using? So I saw a patient many years ago now, who came into the hospital obtunded. I couldn't wake him up for 24, 36 hours. And it turned out he was using cocaine for several days, maybe at least 2 to 3 days straight. So he was catching up on his sleep. And we did a whole entire $1 million workup to try to find out the cause for altered mental status. So I would want to know whether, if is it possible that he's using cocaine many hours at a time and not sleeping, and is this all just sleep deprivation? Seems unlikely because it wouldn't explain other findings in his presentation. But at least that's something I always keep in the back of my mind if I see patient with altered mental status. I ask them, have you been? That's something at least you should ask. Have you been sleeping normally? And then, so the food wise, it's interesting. So how long had he been had no access to food, and during that time did he not eat anything at all? Again, this, I guess, Yusuf, to your point, could this be, once you start eating, I've never heard of a case for people developing Wernicke's after not having access to food, but could it be that he was vitamin deficiency, start eating lots of carbs, and that's why he's having a Wernicke's? So that's the only other thought I have.
Okay, Mike, back to you.
Absolutely. I will mention that I do not have great answers to any of those questions, Dr. Chang.
Okay. No problem.
Okay. Okay, perfect. I just wanted to see, there were some questions I think here before the next aliquot. I wanted to just check in to see if you've sort of answered those, or if there's any more questions that Yusuf, if you want to ask.
I think this is I'm okay. I'm fine. If other people, Yusuf has questions or someone else does, yeah. So
yeah, we can go to the next aliquot, and then we can see what questions we have after that.
Sounds great. Okay, moving on. So now you go to see the patient. Vital signs: afebrile 98.1, pulse is 65, blood pressure is 130 over 70s roughly. He is saturating at 92% on room air with a respiratory rate of 14. On exam, he is in general somnolent, hard to awaken, but intermittently lucid, as we talked about. He has no jaundice or scleral icterus. His neurologic exam is challenging because he's not following instructions very well, but you can see that his face is symmetric, his eyes open symmetrically as well, pupils are 3 millimeters and reactive, and with non-purposeful movements, he is moving his head equally to the left and to the right. His speech is rather mumbled, hard to make it out. And you think maybe he's 4- out of 5 diffusely, but again, very challenging to do a good strength exam. He is moving all limbs equally. You do note Asterix on your exam. In terms of his extremities, just diffuse anasarca is sort of the most prominent thing you notice. He's got 3+ in the lower extremities, 2+ in the upper extremities, as well as the sacrum, and then kind of 1+ periorbital edema. There's pretty significant facial swelling around the eyes. He has crackles in the right lung base only, no JVD, cardio exam, regular rate, normal S1, no S3. He has sort of a diffusely tender abdomen, but not peritonitic, no hepatosplenomegaly. And then in terms of a careful skin exam, you're not noticing any stigmata of liver disease. So no spider angiomata, no pulmonary edema, no kaput medusa. Does not have, and I mentioned already, but not jaundice. And so I will stop there again.
Yeah, thank you, Mike. It seems there are many notable features in this exam. John, any thoughts about the Asterixes on this exam, and how would you tie this into the patient's sleepiness for the past few weeks?
Sure. So I'm sorry, I'm seeing no Asterixes. Is there or is there not an Asterixes?
There is. Yep, it's present.
There is. Okay, sorry. All right. So when you see Asterix, certainly you think about hyperammonemia. The other setting where you see this is with the hypercapnia. And so I would, and the fact that he's only satting 92%, I'm not sure whether he is, let's see, does he have any, is he only, what's his smoking history?
20 years still smoking.
20 years still smoking. Okay. So it's a little unusual to have again, 92% on room air is not normal because the PO2 on 92% on room air would be somewhere in the 60s. And so a patient has a defect in oxygenation here. And so that could be explained so if you want to tie all things together, maybe he has a significant intermittent hypercapnia, which can cause, probably could drop a PO2 into this range. And that would explain ultramental status as well as Asterixis. It's one way to tie it together. The other way, I think maybe more I guess, obvious way to tie together would be the fact that he has a diffuse tender abdomen. I do have a quick question. Was his belly distended? Was there a evidence of ascites?
His belly is rather distended, though it's challenging to tell whether it's just obesity. He has no obvious signs of ascites.
Got it.
No shifting gums, no fluid weight.
Okay. So other possibility here is he has new liver essentially decompensated cirrhosis or acute hepatitis with an increased portal causing portal hypertension, and that could explain his edema. It could explain his abdomen, his tender abdomen. Perhaps he has, we need to tap him to make sure he doesn't have a SVP. And then you mentioned, I think the crackle's only on the right lung. Is that right?
That's correct.
Yeah. So that would be consistent with a hydrothorax. Generally speaking, the people have hydrothorax on the right side. You can have both sides, but most commonly it's on the right side. So you could tie that also in that way. Again, I think I'm stretching this a little bit, but could he have a hepatopulmonary syndrome? And is that why he's desaturating at 92%? And certainly, I think the liver seems more likely source of most of his symptoms. I think liver failure could explain a lot of this, not only his presenting symptoms, but a lot of the physical exam findings. Now, periorbital edema is something that I really haven't seen. That doesn't, so I'm not quite sure what to make of that, but everything else I think can be potentially explained by a new liver issue.
And
okay.
What data would you want next if you were the provider taking care of this patient?
I guess, let's see. So I always like to start with the basic things. So you would, Chem7, LFTs, ammonia level, and then CBC would probably give you a lot of information. And certainly I would want to probably have an ammonia level as well. Yeah.
Mike, back to you.
Absolutely. Okay, so we'll go through the labs then. First and foremost, you sort of are worried about disposition here when you first get to the ED. So you do get a VBG, not an ABG, but the VBG shows a pH of 7.38 and a PCO2 of 43. You notice that he's had VBGs in the past, and they're all sort of within the same range. It looks to be at his baseline. Basic metabolic panel, sodium of 140, potassium 3.9, chloride of 108, bicarb 26, the UN is 11, with a creatinine of 0.77 and a glucose of 93. Calcium is 9 after correcting for albumin, which we'll get to in a second. Phosphate is 2.5, mag is 2.2. In terms of the CBC, he has leukocytes at 8.7. Hemoglobin is 10. You notice that last time he was here, it was 12.5. And platelets are elevated at 474. In terms of the LFTs, his AST is 13, ALT is 20. You get a GGT as well that's been added on in the ED, which is 52, normal on our assay here. T-Billy is 0.34, D-Billy is 0.3, Alk Phos is 146, INR is elevated at 1.5 and albumin is 0.9. The
sorry, what was that?
Which one? Sorry.
I'm sorry. The albumin
is 0.9.
0.9.
Yeah.
Wow. Okay. Wow.
The ammonia, which you asked for, is 110. The BNP is mildly elevated at 133. When he had his STEMI in the past, it was in the 500s. His acetaminophen, alcohol, and gabapentin levels are actually all negative. TSH is high at 17. He has a low normal T4 at 0.9 and a low T3 at 1.1. Lower limit of normal on this assay is 2.3. Do you want more information or do you want to stop there?
I think there's a lot to talk about here, so let's
yeah.
see. Not sure. A lot of surprising things, right? Let's see. Let me just take a look at it. Okay. Well, so I think a couple of things. I don't know what's going on, but I guess we can rule out a few things here. So clearly, this is not hypercapnia based on the venous blood gas, and also the Chem7 bicarb was 26. So that's we can rule that out. The gabapentin toxicity again is not just even before I think we got the level back. The fact that his renal function is essentially normal makes gabapentin toxicity. It rules it out. You really have to have an AKI to get a gabapentin toxicity. So that rules it out. And then other than that, and then so his calcium, what was it? Corrected calcium? Is that 9 corrected or uncorrected calcium?
That is corrected. I think it was 7.1.
Got it. Yeah, right. So there are really no obvious electrolyte abnormalities that would explain his altered mental status, other than ammonium, I guess, level 110. And then the fact that his INR is also 1.5. So it looks like this, based on this constellation of lab values, he's in acute liver failure, right? He has altered mental status. His INR is high, synthetic function is down, and albumin is profoundly low. What I'd like to know, I guess, is make sure that we're not missing other causes of low albumin. So make sure that he's not having a nephrotic syndrome. I didn't get a lot of history about whether we were able to get history about diarrhea. So could he have protein losing enteropathy? So those are I think 2 things I want to make sure that he doesn't have, in addition to liver failure, which seems more likely here. Just one word about, and the TSH of 17, I don't think that would cause this kind of altered mental status. I think generally it would have to be, I would think it would have to be higher, in the ranges like over 50 or 100 before it would cause an altered mental status. So the ammonia, just one word about ammonia. There are other things that can cause high ammonia level than liver failure, and 2 things you should definitely keep in the back of your mind. One is a Depakote, and so Depakote, as you may remember, has a metabolite which inhibits urea cycle. And so in some patients, I think I've seen one case in the last 10 years, so patients who take Depakote can develop hyperammonemia, especially after eating a large protein meal. And so theoretically, they can have altered mental status right after taking Depakote. And the other setting where you also actually do see this, can potentially see it, is in patient with a neobladder. And so if so neobladder is, after patient has a bladder cancer, their bladder has to come out. And so the urologist has to create a reservoir to store urine. And it turns out, and then the ureters are essentially then inserted into so what they do is they take out a small segment of ileum, they sew up the one end, make it a blind pouch, and the other end comes out through the skin. And then the ureters are then inserted into the neobladder, and the small intestine from which the segment was removed and then reanastomosed. It turns out if the urine is allowed to sit for a long time in the neobladder, the ammonium will get reabsorbed. Because you remember acid secretion, acid is not secreted as a free proton. It has to be carried as a buffer, in a buffer, and the main buffer body uses is ammonium. And so unlike the transitional cells that line the normal urethra and bladder, which are impermeable to ammonium, the lining of the gut, in this case the small intestine, are permeable to ammonium. So a patient can present with a significant acidosis and hyperammonemia if they have a neobladder, but that would not be the case in him. But so at this point, I would want to the test that I would want to do is probably get an ultrasound, and then I would want to do I guess a hepatitis serology, and just do the workup for acute liver failure. So and then and then if he has ascites, we'll probably need to do at least at a minimum diagnostic tab to rule out SBP.
Thank you for this amazing discussion. I think we learned a lot, especially regarding hyperammonemia, low albumin states. I wanted to pick your brain about how would you reconcile the hypothesis of liver failure with the elevated platelet count?
Yeah, so that's a very good point. So in patients who drinks a lot of alcohol, they can present with can present with a normal or even a high platelet count, and then so that's one possibility. The other possibility is, could he have, I guess, other differential diagnosis for high platelet count would be something like iron deficiency, or some chronic inflammatory condition. So, there was no history of a GI bleed in him, and someone did mention, I guess, that he did drop a hemoglobin by a couple of points. Now, I guess that could be explained. He could be bleeding, but it's also possible that, could this be dilutional if he's having a lot of fluid weight? And so, but that's a good point. And so it is. I don't have a good explanation for acute liver failure. I guess you're bringing an interesting point. In an effort to tie all things together, I think the liver failure could have explained at least a lot of the lab findings. But is it possible that if he was not eating, if he was nutritionally deficient, could he have vitamin K deficiency, and could that also be because of perhaps the prior gastric history? So we can take that out of the equation, and then you're sort of left with a primarily low albumin and then high ammonemia level. I guess I was thinking liver failure mainly, probably I'm anchoring this on the very high ammonia level, and there's not too many things that cause ammonia level of 110. And so that's the reason I think the liver failure was on my differential, plus the fact that INR was high. But there could be a separate explanation for INR, namely vitamin K deficiency.
Yeah, thank you so much, Mike. We can't wait to hear more.
Okay, sounds good. Just as a heads up, I'm going to give the urine studies. It sounds like those were interested, and then I will just give sort of what Dr. Chang had asked for in terms of some imaging, and then I'll sort of stop there, and then I can give the rest after, just so that it fits with the conversation. So his UA is positive for trace proteins, otherwise negative, not consistent with a urinary infection. Urine protein to creatinine spot is 0.5 grams, and the 24-hour urinary protein is 0.15 grams. His urine drug screen is positive for cocaine, as we expect, negative for opioids. A right upper quadrant ultrasound shows a decompressed gallbladder, common bile duct, which is not dilated, no ascites, and steatosis versus chronic liver disease correlate clinically. And then also it asked for a liver workup, so ANA, complements, HIV, HBV, HCV, ceruloplasmin, AMA, anti-smooth muscle, and TTG-IgA were all negative.
John, I wanted to ask you, how are you framing this patient, and where are you now diagnostically, and what would you like to do next for this patient?
Not what I expected. So let me see. So I think the thing that I'm trying to explain is the high ammonia level is one, and then an albumin of 0.9. In the absence of the liver, other evidence of portal hypertension or cirrhosis, it would be very unusual. And looking at the labs. So I guess the only other, one other thought I had was, could this be, contrary to what I had said earlier, the TSH, could this be some kind of a mixed edema, and he's having the edema. By the way, what was a characteristic of edema? Forgot to ask that.
Oh, it's diffuse. Doesn't really survive.
Pitting edema. Would you say?
Yes. Pitting.
Yes. Yeah. Okay. Yeah. So let me just see. So I don't have a good explanation for ammonia level. I think the albumin, only thing I can think of it is, could he be severely malnourished? So I guess I would be interested if you have a pre-albumin level, that would be other, just to get a sense of what his nutritional status is. That might be helpful. I can't think of any other reasons for his liver issue. As you noted, as you note here, his LFTs are completely normal. The fact that GGT was normal also argues against him using alcohol. And so I can't think of any, just think about this. Ultrasound, really nothing, steatosis. And then what did the chest x-ray show?
Yeah, so I can add the rest of the sort of data now. So the chest x-ray showed a right lower lobe hazy opacity with a small right pleural effusion. No other than that, no other cardiopulmonary disease.
Got it.
Right.
Got it. Yeah. So I'm again trying to tie together some of his presentation. So again, could it be? So one way, I'm going to step back and ask myself, sort of approach it from the standpoint of a volume overload. So he's a gentleman with a generalized edema. So certainly the pre-albumin of 0.9, I think, could certainly explain his anasarca. But since we've ruled out nephrotic syndrome and liver problem as a cause of anasarca, one organ that we haven't ruled out is their heart. Now, the fact that his BNP was completely essentially normal makes left-sided heart failure unlikely. But in patients with a severe right-sided heart failure, they can present with a more or less normal BNP, and his BNP was only minimally elevated, right, 100, so 133. So that would explain certainly the anasarca. I'm just trying to come up with a way of connecting the high ammonia level of 110. If you were to have a right-sided failure, could that somehow cause an ammonia level? I've never seen it, and I really don't have an explanation for his ammonia level of being 110.
Yeah, maybe Mike, you can give us the more data, and maybe that will guide us a little bit further, especially that I know we have a lot of information coming up.
Absolutely, yeah. So I mentioned the chest x-ray. So I think there was a mention of vascular dementia. He did have this would be the best study for it, but he did have a CT head, non-con, no acute abnormality. He also got an MR brain, which showed small vessel disease, but no other acute findings. His echo was performed. It shows EF of 60% and an inferior wall motion abnormality, which is the same from when he had his STEMI back in November, 6 months prior. He had a CT abdomen pelvis with IV contrast. It shows an unremarkable liver and spleen, fat stranding at the splenic flexure that says could represent focal colitis, and then a known 4.5 by 4 centimeter fluid collection along the posterior aspect of the gastric fundus that, again, that was present on prior scans, and then known lymphadenopathy. He had blood cultures drawn, which were negative after 5 days. And then there was some discussion of nutritional measurements. So vitamin D is very low at 8.9. The lower limit of normal for this assay is 20. Vitamin A also very low at 8. The lower limit of normal is 38. And then folate is low as well, 4.7. Lower limit of normal is 5.2. Though B1, B12, vitamin E, and vitamin K are normal. I think I'll stop there, unless anyone has questions.
Yeah, we have a lot of data. I know this is, Mike, this must have been a difficult case for you all treating this patient at this point as well. With all the workup with the echo, going with the normal limits as well. John, where would you where are you putting your money on next, or what are you thinking?
So I guess vitamin D level wouldn't explain. I'm not aware of any. It's hard to tie what his presentation with a vitamin D deficiency. Now, I don't know what the presentation of vitamin A deficiency is, whether that could cause some of these symptoms. The other ones, I guess vitamin K, vitamin E, B1 and B12, they were all normal. So the vitamin deficiency wasn't, I'm not sure. I don't know whether it's a vitamin A deficiency that might at least be contributing to this. Now, let's think about this. Do we have a sense of how long he's been malnourished?
Not more than just like the term months. I don't think we know more than
months.
that.
Okay, got it.
And okay. Intermittent access to food. Most recently, he does have more steady access over the last couple of weeks to months.
I see. And then did the swelling, his symptoms start after he started eating, after he had access to food?
Excellent question. So it's, again, a little bit challenging. He was, of course, not really able to give a history, and it was challenging to sort of nail down some dates in talking with his girlfriend. But it does sort of sound like the 3 weeks of all of these sort of symptoms, he had already been at the person's house for a few weeks before that. So it does sound like there was sort of some stability of nutrition that occurred maybe in the few weeks before this. So yeah, it does sound like he recently got access to a more steady supply of nutrition.
Okay, so I'm just trying to think of, is there anything that can precipitate this kind of presentation after resuming eating? I mean, we typically think of refeeding syndrome, but we think about electrolyte issues and precipitating Wernicke's, but I'm not aware of someone presenting like this when I'm not aware of any condition that does that. So I am not quite sure. I mean, I don't know how to put everything together. I think the ammonia level is really, I guess, a bit puzzling to me, because I don't recall seeing that level of ammonia level without the conditions we discussed. And let's see, is there any other data that we would want? Let's see. Let's see. Yeah, I can't think of any. Do you have any other studies you've ordered?
Yeah, happy to share the rest.
Yeah.
So and not a lot. So we sent off. I saw the fatty acid. We did not send that, but we did send amino acid analysis in case he had some sort of inborn error of metabolism in terms of urea cycle disorder. It shows normal levels of arginine in the serum and urine, normal plasma citrulline, normal urinary orotic acid, normal ornithine serum, normal urinary homocitrulline. Genetic studies for citrullinemia, SLC 25A15, and HH syndrome, SLC 25A13, are both wild type, and so taken together, the genetic analysis says he does not have an inborn disorder of urea synthesis.
I see. Okay.
And then the last thing that we obtained was a transjugular liver biopsy. I can give those results,
okay.
Or in
Sure. Yeah.
Sure. Okay. So a transjugular liver biopsy showed steatosis without fibrosis, consistent with NAFLD, and the hepatic venous pressure gradient was normal at 5 millimeters of mercury. For this assay, greater than 6 was the abnormal.
Yeah, so he doesn't have portal hypertension. I mean, the fact that he had no ascites on either the ultrasound or CT, I think is certainly consistent with the hepatic vein pressure gradient being normal. Now, the only other ammonia level, high ammonia level that I think that can happen, I've never seen it, but this is always written in a textbook, is a patient who comes in with a UTI that with a bacteria that produces urease. And so if you have urea in the urine, and if again urine is allowed to sit in the bladder for a while, then the urease can split urea into 2 molecules of ammonia, because you may remember urea is basically 2 molecules of ammonia fused together. And so you can get hyperammonemia from that, but he doesn't have any history of UTI. So that would, again, that's the only other thing I can think of. But so let's see. Yeah, the only other case I've seen where albumin was less than 1 was a patient who was severely malnourished, and he actually presented with ascites as well. And we couldn't calculate a SAG because his albumin in the blood was 0.9. So any albumin you can get in this acidic fluid has to be less than that. So it's always going to be never going to be greater than 1.1. So he was a case with malnourished and presented with something similar like this. But I don't recall him having a high ammonia level. I think that's what sort of, it's not fitting with this, at least until I find out the diagnosis, whatever the, I'm sure it will bring everything together. But any other tests did you do besides this?
So we got lucky. And so this will be the final diagnosis, if that's okay, Yusuf. Yeah. Please,
Yeah.
Mike, if you can let us know what you were thinking and how did you end up doing this test and what did you find?
Sure. So at this point, I think, we felt pretty confident that he had a protein wasting enteropathy in the absence of sort of any other cause of low albumin, person with extensive GI history, concerning for IBD. Never got a colonoscopy. The patient, sort of was a patient-initiated discharge before colonoscopy, and also declined alpha-1 antitrypsin clearance at stool level, which is another way to make that diagnosis. Well, it is the way to make that diagnosis, other than like a tagged albumin scan, which I don't even know if that's possible to get. And so we felt pretty confident empirically that was at least part of what was driving the albumin. But that didn't help us explain sort of any of the presenting case. And so we actually get a call after the CTA for the transjugular liver biopsy, right? They use, they use radiographic imaging for this. And they let us know that the procedure was successful, but they also mentioned that a splenorenal shunt was identified. And it basically only sort of it lit up in the venous phase. And so rather than being a systemic to portal, it's portal to systemic shunt, which is why it wasn't picked up in the CT-AIV, because that's, of course, an arterial phase time scan. And so they said, this is a portal to systemic shunt and should improve with, hyperammonemia should improve with embolization of this shunt. And so just to give you the history, the patient does end up undergoing that embolization. Patient had already been getting better with lactulose, but after embolization, we sort of saw a pretty dramatic drop in the ammonia a day or two later. And so our final diagnosis, sort of pulling it all together, was that this was, altered mental status secondary to hyperammonemia, which was second to a splenorenal portal to systemic shunt, which really was exacerbated by protein wasting enteropathy. And so we thought, again, hard to prove either, maybe both are true, but recently, gained more access to food. And so all of a sudden a large protein load reaches the gut. And so you get this, bacterial metabolism. And so you get this, load of ammonia. And then also with the hemoglobin drop from 12 to 10, this is a guy with known 30 gastric ulcers and was put on DAPT and Eliquis about 6 months ago. And so we figured maybe there was a little bit of a GI bleed component, although we never were able to sort of prove that. And so that was sort of what we felt pretty comfortable with that diagnosis. But I'm excited to hear what other people are thinking, and if that's an endpoint diagnosis or if something exists beyond that to look for.
Awesome. This is an amazing case.
Mike, what a fascinating case. Did you think that the portosystemic shunt was incidental, or did you think it was related to his history of IBD?
Oh, that's a good question. I don't think we discussed it, and I don't have an answer. Totally.
That's okay. John, did you have any reflections or thoughts about this case?
No, I don't think I would. This is a fascinating case. This is never seen a case like this. But I think I liked how Mike put it all together. I think it definitely makes sense that he probably had this shunt, I would think, for a while, and then it's in the setting of increased protein load that he developed hyperammonemia. The case I was telling you about, a lady who was atypical for many years as a youngster. I think I took care of her when she was in the 20s. She would only get her ammonia level would only be high in the morning after she has breakfast, and then when you check it later in the afternoon, the ammonia level would normalize. And so I think that makes sense, and also makes sense with the when we are taught, when someone comes in with a hyperammonemia, one of the things you have to rule out is upper GI bleed, and that's because you're giving yourself a protein bolus with hemoglobin, and so that also makes sense. And I think the low albumin of 0.9, again, I think that's we've ruled out you ruled out the heart, lung, and heart, liver, and the kidneys. And then now you're left with malnourishment or protein losing enteropathy. So I think that all fits together. That would explain his, all of the things that how he presented with the swelling from a hyperalbuminemia, his altered mental status for hyperammonemia, and most of his physical exam can also be explained. And so one really a very a lot of things to learn from this case. And so thanks for sharing this.
Thank you so much. We really enjoyed learning from you. This was really a fascinating case. Mike, I just wanted to see if you wanted to share 2 or 3 teaching points that you had from the case, or reflections that you wanted to share with other trainees. And how do you think you could not miss this in the future? It's such a hard diagnosis.
Yeah, I think the most important thing about this case was sort of not anchoring too much, but at the same time, sort of not giving up. If kind of trying to continue to press forward, even when a lot of data is kind of running counter to your hypothesis. So, casting sort of when nothing sort of makes sense, trying to kind of back up and think about this patient just the way Dr. Chang did in terms of volume overload or hyperammonemia or hypoalbuminemia, just trying to think of, just broadly, right, broad differential and how those things might fit into the patient's case. But I think my biggest teaching point here is use radiology as much as you can, and never accept the readout that comes back, the report. Like if you have a question and a specific question that's hard to communicate through the health record, go down and talk with radiology. The next test we would have ordered would have been a venogram if we didn't get lucky with the biopsy just catching this incidentally. But right, I mean, using that knowledge, I would not have known to order a venogram or a CT AP venogram. So, but giving this case to a radiologist, they may be thinking about that because it's some more structural. They think more anatomically, and then they know the limitations of scans in a way that I would have expected the CT with IV contrast to find it, but because it's a reverse flow, you don't. So I think for this case, use your radiology colleagues. Don't be afraid to go down. They're more than happy to teach almost always. So, and they'll love to go through scans with you. So I've made that part of my practice since, that whenever we order at least a CT scan, if we have time, we try to go down as a team and go over the scan with the radiologist. You just learn so much more.
Yeah, we definitely love our radiology colleagues. I think the patient is very lucky that his team was so persistent that you figured out the etiology in the end, and it was a reversible cause. And I think they're very lucky to have gotten you as a provider. So thank you both, and thank you everyone for joining, and hope you have a wonderful Monday evening.
Thank
Thanks so much
you.
for having us.